We frequently see patients with chronic bladder pain and persistent anxiety who fail to improve despite robust methylation support. Their system simply overflows. In clinical review, we find a recurring theme, a focus on MTHFR and homocysteine recycling that ignores the downstream consequences of that cycle. We are investigating whether this unaddressed pathway correlates with the presentation of interstitial cystitis, histamine intolerance, and chemical sensitivities in these complex cases. Homocysteine follows three primary routes. While the upward pathways facilitate recycling, transsulfuration represents the body's only dedicated disposal route. This disposal route also functions as a manufacturing center. It is responsible for producing glutathione, taurine, and sulfate. Patients who react poorly to sulfur-based foods often assume they have a permanent genetic defect in the CBS enzyme. However, clinical sulfur intolerance is typically a reflection of a functional, physiological imbalance within the biochemical pathway itself. To identify why this mechanism fails, we need to analyze a case where standard interventions were unsuccessful. We will use a peer-to-peer case review to dissect the lab markers and symptoms of a patient with these overlapping sensitivities. Resolving these cases requires shifting our focus from unchanging genetic data to the active metabolic bottlenecks occurring in real time. SJ presented with bladder pain, histamine reactions, and anxiety. Her labs revealed low homocysteine alongside elevated cystithionine, MMA, and xanthuronate. This is the primary clue. The transsulfuration pathway begins with the CBS enzyme, which acts as a gatekeeper. It converts homocysteine into cystithionine using P5P. As CBS pulls homocysteine through this gate, it simultaneously produces hydrogen sulfide gas. SJ's labs indicate that her CBS gate is functionally stuck open, allowing homocysteine to flood the pathway. This state, known as CBS upregulation, causes the body to dump homocysteine down the transsulfuration route at an accelerated rate. In this context, a low homocysteine reading indicates that the system is losing its metabolic substrate too quickly. We see the evidence of this in SJ's elevated cystithionine. The pathway is receiving material faster than the subsequent enzymes can process it. Operating at this speed rapidly exhausts the nutritional cofactors needed for the rest of the cycle. SJ's low homocysteine is the result of an uncontrolled biochemical flood that is overwhelming her system's capacity for balance. To understand why this flood is painful, we have to look at the products this pathway is intended to create. Glutathione is the body's primary tool for detoxification and managing oxidative stress. Taurine supports bile flow and helps regulate the central nervous system. Sulfate is necessary for connective tissue and the protective glycosaminoglycan lining that shields the bladder wall. When CBS is upregulated, the accelerated breakdown of cystithionine produces a specific toxic byproduct, ammonia. The localized accumulation of ammonia increases as the pathway runs faster. This excess ammonia directly depletes the body's supply of BH4. Because BH4 is a necessary cofactor for neurotransmitter synthesis, its depletion leads to a drop in dopamine and serotonin production. This drop correlates with SJ's experience of brain fog and anxiety. Her mood and bladder symptoms are tied to a system that is actively flooding her nervous system with metabolic waste. The elevations in SJ's xanthuronate and MMA further suggest that she has exhausted the B6 and B12 required to maintain this speed. All of this material reaches the final choke point, the SUOX enzyme. It functions like a massive highway suddenly converging into a single toll booth. A large volume of sulfites attempts to pass through the SUOX enzyme to become sulfate, but the capacity is limited. This limitation causes reactive sulfites to back up into the tissues. This backlog is the underlying cause of clinical sulfur intolerance. This explains why foods like garlic and broccoli, or supplements like NAC, can trigger such severe reactions. The patient is reacting to inadequate sulfur processing rather than the sulfur itself. We must consider if this dysfunction can occur in the absence of a genetic mutation. Clinical evidence suggests that mold toxicity, chronic infections, and oxidative stress can force the CBS gate open regardless of genetics. Effective management requires addressing these physiological drivers rather than focusing on a static genetic report. The clinical strategy for resolution follows three pillars: reducing the metabolic burden, supporting the enzymatic bottlenecks, and restoring systemic balance. Permanent sulfur restriction is problematic, as it eventually starves the bladder lining of sulfate and reduces glutathione production. We support the SUOX bottleneck by providing molybdenum, which is the necessary mineral for clearing the sulfite backlog. We also replace the cofactors exhausted by the pathway's speed, specifically using hydroxycobalamin and P5P. Utilizing thiamine and butyrate supports mitochondrial function and gut health, which helps lower the inflammatory signals driving the pathway. To review, in these cases, low homocysteine indicates rapid metabolic dumping. Sulfur intolerance is a sign of a jammed processing mechanism. Genetic data should always be validated with functional lab testing to confirm the current state of the pathway. Systemic metabolic dysfunction frequently drives localized conditions like interstitial cystitis. By managing transsulfuration as a dynamic, interconnected system, we provide a clear clinical strategy for patients with complex sensitivities to move toward recovery.